Good evening to everybody, and thank you for giving me this opportunity to speak on this topic. And I find it's a very difficult topic because the next 10 to 12 minutes, I have to justify what is the best out-of-the-box treatment. We have the two treatment modalities. One is the pharmacological treatment, and the second is the interventional approach. And I mean to say that the revascularization it can be done through either graft surgery or to be like percutaneous coronary interventions. As you know, so in patient who are having acute coronary syndrome in pre-existing renal disease is a very complex interplay of different hormonal system like the sympathetic hormonal system, the natriuretic peptide and the renin-angiotensin-aldosterone system. So, and beyond that, there is significant oxidative stress and insulin resistance because 70 to 80% of the patient presenting with acute coronary syndrome with pre-existing kidney disease and diabetes, and there is significant inflammatory response in this group of patients, and subsequently there will be endothelial dysfunction and then plaque erosions and plaque ruptures. And that is why the CKD is also associated with significant morbidity and mortality. And also importantly that whenever we start in a pharmacological therapy, so there is a complex interactions of different molecules, and because of the creatinine clearance becoming lower, so the drug and drug interactions are significantly higher. So these are certain challenges we have to encounter in our clinical practice while treating ACS patient with existing renal dysfunction at the admission. Before proceeding to treat this kind of patient, we must know what is the stage of the kidney disorder in this group of patient, and we must know the stage of the CKD patient subject to the GFR and also proteinuria. So it is there are 5 classes, and the class 3 is again divided into 2 subgroups. And accordingly, we decide the stage of the existing disease or CKD in this group of patients. As you know, once the creatinine clearance declines, the number of hospitalizations with acute coronary syndrome, cardiovascular mortality, and morbidity significantly or exponentially rises. There are some difference noted in terms of the pattern of the acute coronary syndrome in the symptomology. As the creatinine clearance declines, the patient become less of having angina and more of having shortness of breath and dyspnea. And the prevalence and the frequencies of STEMI comes down as the creatinine clearance decreases. But the STEMI and unstable angina proportion increases once the creatinine clearance decline. And also, we have been seeing more frequent left ventricular blood patient once the GFR decline. So one of the most fearsome and dreaded complications that can happen whenever we try to do interventions with giving contrast exposure to the patient, and then the patient can land up with contrast-induced nephropathy. So to exactly know the ablation status of the patient and the GFR and the creatinine value, and also the load of contrast that we want to inject in that particular patient is paramount importance to prevent contrast-induced nephropathy in this group of patients. So as you know, the hypertension, congestive heart failure, the elderly population, if the patient is having anemia and diabetes, and as I already said about the contrast volume, these are the significant risk factors to develop contrast-induced nephropathy. Once the patient develops contrast-induced nephropathy during the PCI, so there is exponential rise in the mortality in this group of patients. One important syndrome that we must recognize is the cardiorenal syndrome. There are 5 types of cardiorenal syndrome. In patient with acute coronary syndrome, it is a type 1 because there is hemodynamic perturbation and there is hyperperfusion to the kidneys, or because of the increase in the sympathetic drive, natriuretic peptide levels, and also the activation of the renin-angiotensin-aldosterone axis, the patient can develop a renal failure. So this is a type 1 cardiorenal syndrome we often encounter in patients with acute coronary syndrome. And once the patient is completely treated, then there was significant improvement in KPI, and then the patient creatinine level become normalized. So what is the current management of this group of patients? So the most important is that we first stabilize the patient whenever they come with the acute coronary syndrome, and then we have to find out the strategy, what kind of pharmacological treatment to be started, and if the patient presently steady, and if it comes within a 12 hours time frame, so the best treatment we are having the thrombolytic treatment. But the problem is that in the CKD patient, once there is an increased risk of ischemic events, and the other way there is also increased risk of bleeding. So it is a double-edged sword kind of situation we are encountering. So if we can thrombolize this patient, and then there will be signs of critical organ bleed like intracranial hemorrhage, and then it might lose the patient. So we have to be very careful while choosing different type of regimen. This is the modification of diet in renal disease, and to find out the GFR. And this is commonly used the copropane gold formula to find out the creatinine clearance in this group of patients. But once the creatinine clearance significantly lower, and the use of this this particular formula to precisely know the renal function is become more of spurious. So the first is the antiplatelet therapy. So as you know, the aspirin is basically eliminated by liver and then excreted downstream in a very small amount in urine. So, and there is not much of interaction in the CKD patient while using aspirin. And aspirin is a aged-old molecule that can prevent ischemic heart disease, recurrent ischemic heart disease, and then acute coronary syndrome. We load the patient with aspirin so that we can inhibit the platelet as early as possible to get the maximum benefit. There are other molecules like tetrapilar. Tetrapilar can be safely given in moderate renal dysfunction, but in dialysis patient, so there is limited data while using this molecule. In one hand, we have oral antiplatelet. The other hand, we have the injectable antiplatelet. We call it the ZP2B3 inhibitors. Among the three ZP2B3 inhibitors, this is the apixaban, actifibetide, and the tyrosine. So it is the apixaban. This is mostly safe in patients with moderate to severe systolic in creatinine clearance, reduced creatinine clearance. But the tyrosine dose must be reduced in patient with CKD when the creatinine clearance is significantly low, if it is less than 30%. These are some of the data. Most of the evidence was collected from the antithrombotic trialist collaboration trial, where it was shown that there is not much of interaction in CKD patient with aspirin, and aspirin is safer, which is usual dose like 75 to 150 mg in patient in acute coronary syndrome with pre-existing kidney disease. So now come to the clopidogrel, that is the commonly used P2Y12 inhibitors, because given to patient with acute coronary syndrome. So most of the evidence was collected from the PO, CREDO, and the CLARITY-TV. As you know, in most of the randomized control trial, the patient with creatinine clearance less than 30 are excluded. And it is very difficult to substantiate the benefit of this antiplatelet therapy in patients with CKD. But these are some of the trials included some of the CKD patients with moderate renal dysfunction, and it was proven that the clopidogrel may be safe in acute coronary syndrome to prevent further ischemic events. But we have to be very careful by giving this molecule in CKD patient where creatinine clearance is significantly low, like less than 15 to 30. GP2B inhibitors sometimes we use in patient with ACS, particularly upstream PCI cases, or where in coronary angiogram we see that there is a lot of thrombus in the coronary arteries, and to prevent the propagation of the thrombus, and if we place a strand there to prevent various strand thrombosis. So the GP2B inhibitors can be used, but mostly we have been using apixaban, and because the dose modification is not required in patient with moderate renal dysfunction. But in case of tyrosine, we have to reduce the dose by 50% if the patient having a creatinine clearance of less than 50. In case of thrombins, heparin can be used, unfractionated heparin, and given a dose of usual dose we given for heparin, and then if enoxaparin is used in patient with creatinine clearance less than 30. We reduce the dose to 1 mg subcutaneous in 24 hours. So this is the dose modification required in case of enoxaparin, but in case of heparin, it is not required. Valvaluridine is sometimes used, particularly in patient during the PCI, and valvaluridine interaction with CKD patient is significantly low compared to the other molecules. But if the patient is having very severe renal dysfunction, if the creatinine clearance is less than 15, so it needs some modification. 50% reduction of the valvaluridine dose is required. Fondaparinux is because of once daily dose, it could be patient friendly, but if the creatinine clearance is less than 30, Fondaparinux is not given. It is in fact contraindicated. So the pulmonary therapy is a very important aspect in STEMI patient, but the problem is that it might lead to severe critical organ bleeding like intracranial bleed, and particularly the fibrin specific agent may be safer compared to the non-fibrin specific agent like streptokinase. Other anti-ischemic therapy in case of, if we talk about the beta blockers, and bisoprolol may be safer compared to the others because its metabolism is not through kidney. And in all the randomized controlled trial, there are the 3 beta blockers like metoprolol, bisoprolol, and carbidopa. They are shown to produce good beneficial effect in ACS patients. So earlier we can start this molecule, more will be benefit will be obtained. Use of AC inhibitors or ARB, we must start these molecules within 24 hours. But the problem is not the worsening renal function, but it is the hyperkalemia, because it might lead to various complications and life-threatening complication. So in majority of the patient with ACS, there is in the initial phase there might be 30% increase in the creatinine, but usually 50 to 90% of the patient usually subsides. But the problem is hyperkalemia. It is a progressive hyperkalemia that can lead to life-threatening complete heart block or other arrhythmia events. Aldosterone blockade. So the problem is that in CKD patient with moderate renal dysfunction, it might lead to hyperkalemia, and that is why in patient with creatinine 2.5 for man and more than 2 for women, aldosterone blockade are not recommended. What are the other means of therapy in patient with ACS patient represented with the emergency department with pre-existing renal disease? So the revascularization process. So there are the surgical revascularization and this percutaneous method we call it angioplasty. And the problem that we have encountered is that the contrast, because we have to inject the contrast. So there was some calculation so that the safe limit of the contrast injected in during the procedures can be evaluated. There is no definite data on this type of revascularization strategy, whether it is CABG or whether it is percutaneous coronary intervention is safer. Because this patient not only having high ischemic events but also having high bleeding risk. So what is the optimum loading dose of the antiplatelet therapy before the percutaneous interventions like primary PCI is yet to be recognized. But as there was robust data on primary PCI during this STEMI patient, so I think this is one of the modality that should be it is actually underutilized, but we in clinical practice should use this the primary PCI if the patient comes at the appropriate time, and that might lead to mortality benefit. So after studying extensive literature, I have seen that the literature has been very consistent in showing an increased risk of percutaneous coronary intervention in patients with chronic kidney disease. And that there is only few data exist from randomized control trial to dilation. But important is that we need to assess whenever we are doing an angiogram in ACS patient, what is the coronary anatomy, what is the collateral supply, what is there a diffuseness of the disease? Because in most of the patients with existing kidney disease, we have found diffuse coronary artery disease, diffuse atherosclerotic disease, and the calcium load is significantly high. So, and this group of patients putting a stent without preparing the bed might lead to more complications like stent thrombosis. That is why, and also important is that so we need to do complete remusculation. Primary PDCA patient is one subset of patient where we might get benefit in STEMI patient, but in STEMI patient, if we see the extensive disease, diffuse atherosclerotic disease, triple vessel disease, and if these are CKD patients having mostly calcified lesion, and that without preparing the bed and pushing the patient for stenting might lead to more complication. And also it is important that in the different trials, like the Baruah 2D and Freedom trials, they are endorsing more of complete remusculation, and the complete remusculation can be done by CABG, and the chances of complication and graft occlusion are significantly less if we adopt the complete arterial remusculation. In the recent era, because the stent spots are reducing, and using this kind of stent like Synergy or the Onyx, where the stent, the spot size is 60 to 70 micron, and there are this Synergy or other new generation stent and can be used in the high bleeding risk patient, and where we can even after 1 to 3 months of the DAPT, we can withdraw DAPT. Particularly the high bleeding risk patient might change the scenario of treating revascularizing this patient, acute coronary syndrome patient with pre-existing CKD.
Dr. Rituparna, you have to summarize.
To conclude, there are concerns about using the aggressive reperfusion strategy, which implies both fibrinolytic therapy and primary coronary revascularization procedure. Particularly in patients with STEMI, trials have shown the effect of the thrombolytic agents in reducing mortality, but NRS was not performing many or severe CKD on admission. The risk of bleeding, particularly the intracranial hemorrhage, constitute a reason for less frequent use of thrombolysis in patients with CKD. However, the primary percutaneous coronary intervention may be a good therapy by treating this patient. CABG may be conflicting, but in CABG in early CKD may be beneficial in this group of patients. Thank you for your kind attention.